And good morning. It's Eileen Bird with 2Life, the executive director here. And as people are signing on, I want to say good morning on this somewhat warm day that we're going to have here in the Capital Region. But you are on the Beat the Odds program that will be presented here this morning. And we'll be getting going in just a couple of moments. And so as you will see here, we have, I guess we're getting some of our slides here in line and in queue for starting the program. But as we wait for a few more people to join in, and obviously this is always one of those times where you want everybody to get in and get all the information. But I want to start with just a couple things here. So you probably noticed we're working in a Zoom webinar environment where everyone will be muted and will not be seen. However, that does not mean we don't want to hear from you. And so following our presentation this morning, we will have time with Dr. Canetta to do some questions and answers. And so you'll notice at the bottom, and by now, probably most people are nicely familiar with the chat feature and the Q&A, and you can post questions in either of those boxes as Dr. Canetta makes his formal remarks, and that's going to take about 45 minutes. Then we will follow up that time period with our questions and get them answered. But we're going to monitor them throughout the program and start to address them as the morning progresses. Okay, so I want to say thank you to our sponsors for today's program. We have been supported for many years by the Soroptimists of Saratoga County, which is a very lovely endeavor of individuals that they've been around for a very long time, and it's important to them to support programming that benefits women in particular in our community, but men as well are dealing with breast cancer. 1% of all breast cancers happen in the male population. I also want to thank CDPHP and Fenimore Asset Management. And so again, if you've got any questions, we will monitor as the morning goes on. But now I really would like to introduce Mara Ginsberg. Mara is the person who started 2Life in 1998, which almost seems like around the corner ago, but perhaps to her it seems like an eon ago. No. And Mara was the inspiration for the Beat the Odds program, including the Cynthia Shanker Memorial Speaker. So Mara, I'm going to turn it over to you and say welcome. I'm glad you're with us this morning, and please take it away.
So thank you everyone who's on the call, and to anyone who's listening at a later date and time or watching. I'm very excited to have this program today, and we're all going to learn quite a lot. So first, we've named this speaking opportunity on an annual basis for Beat the Odds. Any of you who are with us, who have been with us since the beginning, know that we used to do this very program at the racetrack, hence the name Beat the Odds. It was, a little play on words. We've had some fabulous programming over the 24 years that we've been doing this this event. And a few years ago, we received a donation in memory of a dear supporter and a longtime board member, Cynthia Shanker. So the goal of that donation is to help us bring world-class speakers right to our doorstep. Today we're not in person, unfortunately, but we are very excited to have today's speaker, and that is Dr. Renzo Canetta. And you'll hear in a moment from his accent that he's Italian. And you'll see from the screen that he's semi-sitting in Milan, Italy right now, at least the screen behind him, but he hails from New Haven, Connecticut when he's here in the States, which is a lot of the time. Dr. Canetta has an amazing career trajectory. you know, among other things, he's quite humble, but at some point as I got to know him, I learned that he actually was instrumental in, for example, bringing Taxol to market. So that's for anybody who's been involved with breast cancer, either as a patient or anyone who's intrigued by the trajectory of the treatments. That was a game changer years back, and still obviously part of the toolbox for treating breast cancer. But going back, he studied in Milan, and his early years in his career were actually at the, I'm going to mess up this name, Istituto Nazionale Tumori in Milan. And he focused there on clinical trials in lymphoma and gastrointestinal tumors. And then in 1980, he joined Bristol Myers Squibb, and he had many different roles as he moved up the food chain, if you will, there as an esteemed clinician and scientist. And again, he brought so many different drugs to market that, including the Taxol and taxanes. In fact, 18 different drugs, 2 outside oncology, and got 50 additional products involved in moving forward. So he's really got a long history of knowledge of how breast cancer treatment has changed, and he's going to and he retired from Bristol Myers Squibb in 2015, and he consults and provides services like this to not-for-profits like us. So we're really blessed and lucky that he had the time to spend with us today. And he has his finger on the pulse of what's coming down the pike. And that's what's new right now and what's coming soon to a drugstore or a physician's office near you. And he's going to share these insights with us. And the goal of this program is, you know, we can't solve anybody's individual medical issues today, but we can provide information that we hope gives hope to anyone who's struggling with the disease, and move forward from there. So without further ado, I'm going to introduce Dr. Canetta, and we're going to be back in touch with you for Q&A when he's done. Thank you so much.
Thank you, Mara. Thank you, Eileen. Thank you to the To Life organization, but in particular, thank you to the people that I don't know that are joining us this morning. Everything that we're doing it for our patients and to advance and improve their treatment. First of all, I'll start with my disclaimer. I have a long history, somebody says too long, history of relationship with Bristol Myers Squibb company. I retired in 2015. Currently, I have no commercial affiliation. And I want to inform you of the fact that for today's presentation, I've been focusing on the most recent things that have occurred in the treatment and in the management of breast cancer. And most recent, I really mean within the last 12 months, with a great focus on what has happened just a few months ago, in particular, the reports at the annual meeting of the American Society of Clinical Oncology, of which I am a member. But keep in mind that the guidelines, the recommendation that I will quote, there are ASCO recommendation. There are other recommendations, for instance, the European Organization of ESMO, of which I'm also a member, or NCCN in this country that dictates, in many cases, the reimbursability of treatments. The title of this presentation was Progress and Challenges, and there are very good news in breast cancer. And the very good news are represented in this curve. There has been a constant reduction of mortality for patients affected with breast cancer. And the curve continues to go down, continues to go down, continues to go down. What it means is that breast cancer that used to be an acute disease is now effectively become a chronic type of manageable disease, and it can last for many, many, many years. Unfortunately, even in this country, there are still disparities and differential results in the effect of the treatment of breast cancer. In particular, minorities are still enjoying a reduction of the mortality, but not at the same magnitude as it happens in the majority of the population. Now, as I said, breast cancer has become a curable disease, particularly when taken in the early stages, particularly when taken even in the regional type of invasion by the disease. And these are recent data from the American Cancer Society, quoting the SEER database. And as you can see, the mortality has gone extremely down. And we are witnessing something that we have seen happening in other tumor types and in other pathology. These type of diseases are becoming chronic diseases rather than acute diseases. Now, clearly one of the secrets is to arrive to a very early diagnosis of the disease. And in particular, in breast cancer, screening and early diagnosis saves lives. A recent publication at the American Society of Clinical Oncology meeting this year, 2 months ago, has quantified the improvement of overall survival that continues year after year after year to reduce by 31% of the mortality in all the subtypes. And even when you separate by the major subtypes of breast cancer, the hormonally positive tumors, the HER2 positive tumors, and even the triple negative, you see major reduction of the mortality happening year after year after year. Now, unfortunately, we all had to live through the pandemics. And what the pandemics has done in breast cancer and also in cervical cancer has produced a reduction of the frequency or the incidence of screening visits that women are undergoing. Interestingly enough, this has not happened for colorectal cancer. As you can see, over the year of the pandemic, the frequency has remained the same. I am afraid that the reduction of the time of the early screening may result in negative outcomes for patients that didn't undergo on a timely way to the procedures of screening and early diagnosis. Now, there has been a very reassuring result concerning breast conservative surgery, or BCS. And these are very long-term data that prove and document that when a reduced amount of surgery is conducted and followed by radiation therapy in early stages, the results are actually even better than the one that one can obtain with radical mastectomy that used to be the most common practice until, let's say, 20 years ago. This is very reassuring, and what has been even more reassuring and confirming has been the fact that the patients themselves have reported that their quality of life has been better when undergoing reduced surgical procedures as compared to women that undergo the radical mastectomy. And these are long-term, 10 years results, and they prove the fact that quality of life has improved. Now, as I said before, we divide the breast cancer in a number of 3 major categories. The one that is the most frequent is the one of the hormonally sensitive breast cancer. Usually we refer to it as ER, or estrogen receptor positive, but that contains also the progesterone receptor positive, and in very few cases also the androgen receptor positive. We refer to them as HR+, And these, in the vast majority of the cases, are patients that have a negative HER2 condition. Now, what has happened in the last few years is that 3 major trials, very large trials, 2 conducted in the United States, TAILOR-X and REXPONDER, and 1 conducted in Europe called MINDACT, have proven that for patients that have a limited disease and a very low genomic recurrence score, these patients can go on without receiving cytotoxic chemotherapy. This is a major observation, something that I have to say I have been personally involved with in supporting the MINDACT study. And the happy results is that a large number of women no longer need to undergo chemotherapy after their breast cancer initial surgery. An interesting and somehow intriguing results has been reported this year from France, from Dr. Etienne Brain. And in his study, a very large study of almost 2,000 women, but these are women that are aged more than 70 years, even despite a high genomic grade index, standard chemotherapy did not add to the overall benefit. This is somewhat surprising, but actually points to the fact that in more senior women, the avoidance of chemotherapy can be done and can improve quality of life. Moreover, there have been other smaller subset of the breast cancer population, luminal A histology, ductal carcinoma in situ, where specific studies, 1 in Canada, 1 in Australia, have proven that even other modality can be reduced or avoided. In the Canadian study for luminal histology, these women did well even without radiation. In the Australian study for ductal carcinoma in situ, you could avoid either radiation or even hormonal therapy. Now, you need to be cognizant of the fact that these are results that pertain to a very, very specific type of breast cancer population. So they're not generalized strategy recommendations. How many tests, genes do we need to test? Well, these are the 5 FDA-approved tests and the number of genes that are tested. The most frequently used are Oncotype DX from Wisconsin and MammaPrint from California. They test 21 or 70 genes. I expect that as we proceed, there will be additional testing and diagnosing techniques, and we will continue to refine this modality of diagnosing breast cancer. These are the ASCO most recent recommendation, and they pertain to the adjuvant treatment. This is what is being given after the initial surgery. And ASCO recommends that for this population of hormonally positive tumors, Oncotype DX, if node negative, or Oncotype DX or MammaPrint, if node negative and post-menopausal, can be utilized to detect the risk of recurrence, but also to dictate the treatment. Unfortunately, we don't have too many data for patients that have more than 3 nodes, and we're continuing to study this population, as you will see a little bit later. Now, this is very interesting. You know, I'm an old oncologist. I've been involved in breast cancer, as Mara indicated, in my early years, 6 years at the National Cancer Institute in Milan. We did conduct the famous CMF study, where combination chemotherapy was added to surgery and proved to be very useful. Interestingly enough, today's trend is to reduce the use of chemotherapy and provide for a better quality of life by utilizing newer drugs and newer diagnostic tools. In fact, hormonal therapy has evolved a lot. Initially, oncologists of the last century, if you want, used to use hormones following surgery. Tamoxifen has changed the game. And then after tamoxifen, the aromatase inhibitors came, and finally, the selective estrogen receptor degraders come to fruition. And in fact, when you look at this type of tumors, the strategy is always to block the production or the assemblage of the hormonal receptor. And you can do that with aromatase inhibitors. You can do that with the tamoxifen that alters the receptor, or you can do that with fulvestrant that degrades the receptor. So these are very different strategies that, by the way, are not cross-resistant. They can improve the approach and prolong the treatment of these tumors for a very long time. This is the history that started in 1956 with the approval of the first treatment for breast cancer in this country. And the most recent approval actually came now more than 20 years ago with Faslodex, the selective androgen receptor degrader. Now, interestingly enough, there is now a full list of agents that follow in the selective estrogen receptor degradation approach. They're all in clinical trials. A couple of them are interesting. One is called elacestrant, and elacestrant is belonging to this particular class of agents, but it's also been proven to provide efficacy in patients whose receptor for estrogens has mutated. That's an important observation. Now, I learned yesterday, and this is really very, very recent news, that there is another agent in this class that is called only with a number, but it belongs to the same class, is a selective estrogen receptor degrader. It has shown some positive results in mutated reception. And yesterday, the FDA has given a fast track definition for the future approval of this second agent. Elacestrant has been submitted to the FDA for approval less than 2 months ago. So stay tuned, because this may become available fairly soon. As I said, there are also androgen receptor, and this particular agent, which is somewhat unique, is now in clinical trials, is not yet approved. And it is in clinical trial, but in combination with targeted agents. And we will see this to be a theme in the treatment of hormonal sensitive breast cancers. Now, there are still a number of open questions for hormonal treatment, and many of them have to do with the duration of treatment. In young patients, premenopausal, the question is still open whether 10 years of treatment are needed instead of only 5. For the general population, again, still a very open question. And why open? A couple of important recent studies, one from Austria, indicated that comparing 5 + 2, so 7 years of treatment, versus 5 + 5 years of hormonal treatment did not make any difference. So the Austrian study suggests that the shorter duration of treatment is equally effective. However, the Italian study that asked a similar question about the duration, they started with 3 versus 5 years, and they added 2 to 3 years additional. So that would be 5 or 6 years versus 8 years of treatment. And they did show actually that with letrozole, a different aromatase inhibitor as compared to anastrozole, the benefit was better with longer treatment. So at the present time is still an open question, and your oncologist will need to decide together with you what is the best drug to choose and what is the best duration of treatment for you. Another interesting development is the fact that now we are refining diagnostic tools and looking for tumoral DNA in the blood can actually help a lot. And it can help identifying patients that are at risk of recurrence or patients that they may not need additional duration of treatment. So again, this is a type of diagnostic tool that is not yet FDA approved, but I'm very, very convinced that will be used more and more frequently in the future to dictate the type and the duration of treatment for breast cancer. Now, the big revolution in the treatment of hormonal treatment of breast cancer happened with tamoxifen in '77. But now we are in the era of genomic targets. And now the standard of care has evolved to add to standard hormonal therapy a specifically targeted class of agents. And these agents are either the mTOR inhibitors or the CDK4/6 inhibitors or the PARP inhibitors, and the most recent one was alpelisib in the PI3K inhibition. So these are all areas of the genomic profile of a tumor that can be affected with specific drugs. Interestingly enough, the PARP inhibitors were originally developed for ovarian cancer, and their approval for breast has followed only 4 years later. These on the left are the ASCO, the American guidelines. On the right, you have the ESMO, the European guidelines. They're fairly similar. ASCO recommends to start with the CDK inhibitor, or in the presence of a PI3K mutation to switch to alpelisib, or in the absence of this mutation to go on with the mTOR inhibitor. The Europeans actually put everything on the same plate, and they recommend go after the genomic target that you have identified, if there is one. Now, the CDK inhibitor, there are now 3 of them that have been approved by the FDA: palbociclib, ribociclib, abemaciclib. They are all very, very similar in their efficacy and in their safety profile against advanced disease. However, they are not the same when it comes to adjuvant treatment. And even if all of them are approved for the treatment of advanced disease, only abemaciclib is approved for the adjuvant setting. And in fact, is approved in a very specific population with HER2 negative tumors, hormone positive tumors, and a proliferation score called Ki-67 high. Interestingly enough, ASCO and NCCN provide guidelines that are actually more relaxed than the FDA label. And they actually recommend this treatment in the adjuvant setting, even for a larger population. The other interesting thing is that, as I said, not all of them are the same. And unfortunately, palbociclib reported very recently the results in the adjuvant setting, and the study of palbociclib was not a positive one. So for the time being, abemaciclib is the only one approved for the adjuvant setting. We're all waiting for the results of ribociclib that are not yet mature. We expect them to come at the end of this year or early next year. And of course, as always, there are additional agents earlier in development that have been developed. The PI3K inhibitors are the last class that has become available, and alpelisib is now approved, and is approved in combination with fulvestrant and for advanced disease only. Adjuvant trials are going on. Now there are a number of other agents of this class, and why do we need additional agents in this class? That is because we're going to look at the specific subsets within the genomic mutation. So one is going after the PI3K alpha, the other one is going after the PAN mutant, the third one is going after PI3K delta and gamma. So as we learn more about these genomic characteristics, we can think to develop drugs that are specifically aimed at these specific genomic characteristics. Now, the PARP inhibitors, as I said, they were originally developed for ovarian cancer, but in June of 2021, olaparib was approved also for adjuvant treatment of breast cancer. It had been approved before for metastatic treatment. Now, there are many of these agents that are already FDA approved. However, only olaparib is approved for breast cancer. All the others are either approved for ovarian cancer or for other tumor types, such as prostate or lung cancer, and many are still in early clinical development. One of the most interesting experimental agents does not have a name yet. It's called AZD5305. I'm happy to be able to present to you, courtesy of Dr. Lorusso from Yale University, who gave this presentation in April of this year at the plenary session of the American Association of Cancer Research in New Orleans. So this is not ASCO. And she presented the results for this selective PARP1 inhibitor. So what does selectivity bring to this class? Well, clearly differentiates these agents from the other one that affect both PARP1 and PARP2. But this differential effect makes it so that this drug does not affect the blood counts, anemia, leukocytes count, platelet counts, as badly as the other PARP inhibitors. So again, it promises a further advance in the safety of this class. Equally importantly, this agent has been proven to provide efficacy in patients with breast cancer that have not responded or that have stopped responding to the other PARP1 inhibitor, olaparib and others. So again, this is yet another step further, even within the same class, in developing potentially better therapies. This agent is still experimental. Now, speaking of experimental agents, we're after every sort of additional genomic target we can dream of. And I don't want you to memorize all of these, but yet the teams are going after novel genomic targets. One other team in these three agents is to go after angiogenesis genes. So genes that produce vessels that feed the tumors. Or on the bottom, and you see novel agents that are after novelly discovered genomic abnormalities. But the theme for all these type of agents is that they're always developed in combination with other modalities, be that hormonal therapy, be that chemotherapy, or be that other targeted therapy. So we continue to look for improvement of treatment by combining agents. And in fact, this is the general trend. Whenever possible, we try to associate a hormone therapy with a targeted therapy. And this is a very important trend that covers a large segment of the breast cancer population in today's reality. Now let's move on to the HER2 tumors. Now, these are tumors that traditionally have been thought to be very aggressive, and the presence of a receptor for this factor had been thought in the past, and in fact was associated in the past with a worse prognosis. Things have changed now. And why have they changed? Again, here there has been a revolution that has been started in 1998 with the introduction of trastuzumab, the first of the monoclonal antibodies directed to HER2. And a large number of small molecules, antibodies, or conjugated molecules. That mean when you attach a cytotoxic chemotherapy to, so to speak, the tail of an antibody, you can direct specifically the chemotherapy to the cells that you want to eliminate. These type of treatments have dramatically changed the outcome of women with HER2 positive tumors. In fact, trastuzumab is now approved for metastatic, for neoadjuvant, and even for adjuvant treatment. Pertuzumab and the combination of trastuzumab and pertuzumab are also FDA approved for metastatic, for neoadjuvant, and for adjuvant. Now, the conjugated moieties, adotrastuzumab and famtrastuzumab, so far they are approved, one for metastatic, but also for adjuvant, but only after neoadjuvant treatment has been given before surgery, in the case of adotrastuzumab. In the case of famtrastuzumab, only for metastatic. Now, keep in mind that this particular molecule, because I believe that is extremely important and interesting. These are the ASCO guidelines on top for first line and second line treatment of HER2 positive metastatic tumors. On the bottom, you see the European for first line and for second line. Here, the message is very clear. There is hope, there is treatment, there is opportunity, not only initially, but even for first and second and further line of treatment for these tumors. And in the past, there was nothing for them. Now there are many options, and many options that prolong life, prolong and improve the quality of life of these patients. I told you about this drug called famtrastuzumab deruxtecan. The name is very complex, but this is more than just an active drug. This is a drug that has been approved by the FDA. And in a trial called DESTINY-3, it has proven to be superior to trastuzumab and to Taxane. In a follow-up trial, where this particular drug was compared to adotrastuzumab, it was better than adotrastuzumab. So it proves to be a very, very effective drug in breast cancer. But the most dramatic results have been obtained by this DESTINY-4 trial. These are very recent information. They've been presented in the plenary lecture of the ASCO meeting 2 months ago in Chicago. Now, this trial is very important, not only for the drug itself, but it's very important because it promises to change the standard of care of breast cancer. And it promises to demand better diagnostic tools, better than immunohistochemistry, better than in situ hybridization that are the currently available diagnostic tools. if from today's presentation you need to remind only one slide, I recommend that you fix in your mind this slide. Why is that? Because as of today, when we test for HER2 presence in a tumor, we go by immunohistochemistry. And when all the cells present the receptor, we declare the tumor to be HER2 positive. And this is 15% of the patients. We look also for tumors where the majority of the cells, but not all of them, present the receptor. And then in these cases, we proceed with the in situ hybridization. If the in situ test is positive, then we declare these patients to be HER2 positive. However, if the in situ hybridization is negative, we consider this tumor to be HER2 low or HER2 negative. And that applies also to tumors that have a minority of tumor cells presenting the receptor by immunohistochemistry. Now, this is about half of this population, is a large number of women. And for these women, as of today, what we were offering was standard chemotherapy. We would treat them exactly the same way we would treat the fully negative tumors. Now, the trial and the drug that I've shown to you today changes this picture. I am presenting these results courtesy of the ASCO presenter that have given me the permission to show these results with you today. And the way by which this drug works is, again, by carrying the cytotoxic agent inside tumor cells that are HER2 3+ or HER2 2 or 1+ positive. And then the cytotoxic drug kills the cell. And what does that do? That improves both progression-free survival and overall survival as compared to the standard cytotoxic chemotherapy. These are the results of the DESTINY-Breast4 results. Of course, every drug comes with side effects. And as you can see, standard chemotherapy in that trial produced more neutropenia and more peripheral neuropathy, as we all know from the taxanes and from carboplatin. In the arm that received the new drug, famtrastuzumab deruxtecan, there was more nausea, and there was a novel side effect, interstitial lung disease or pneumonitis, that we needed to look for as we will proceed to use this drug more and more. As I said, this drug is already approved for the treatment of metastatic disease. But if you think of what I said, now there will be a lot of use in the future, I hope, even in earlier stages of disease. Now, I want to reassure you of the fact that the sponsor of this drug has submitted an application for this drug to the FDA while we are in August, last month in July, and the FDA is now rapidly reviewing these results. Of course, with this type of approach, now one always think of how to make it even better. And here, a number of experimental agents that are looking at the receptor, different qualities of the receptor, different modalities of the receptor, and then again looking for small molecules, antibodies, bispecific antibodies that can attach two receptors at the same time, or even tri-specific antibodies that can attack 3 receptors at the same time. So stay tuned, because there is a lot of research going on in this area. Now, the triple-negative breast cancer is the group of patients that used to have the worst type of prognosis. But now, because of what I just told you, there is a large proportion of patients that until now we have considered to be triple negative, that in reality can be treated as if they were HER2 positive because they had HER2-1 or HER2 positivity and negative FISH. Now we have option and effective option even for these patients. Traditionally, this group of patients is the one that underwent cytotoxic chemotherapy. And this was the land of the taxanes. This was the land of ixabepilone, eribulin. The only completely novel approach was provided by this conjugated agent that looks for this TROP2 receptor and brings in a topoisomerase cytotoxic. And this was approved 2 years ago by the FDA. What are people doing with cytotoxic agents? Well, there is a major team that is basically a reformulation of drugs that we know that are effective. Eribulin is being reformulated in a chemical ways. Docetaxel, paclitaxel are reformulated by oral pills or in liposomes. There is a formulation that allows for intratumoral injection. And then there is a reformulation of irinotecan, which is a drug not approved for breast cancer, that actually has the capability to penetrate into the brain and provide efficacy for brain metastasis. Of course, the conjugation of antibodies and chemotherapy has been popular and now is being pursued very actively. De facto, the only new class of compounds is being provided by lurbinectedin. Lurbinectedin is now approved for lung cancer, specifically for small cell lung cancer, but not for the breast cancer today. So we'll see whether it will arrive there sooner or later. Another way to identify the agents that could be effective in the triple negative population has been introduced a few years ago by the National Cancer Institute of this country. And they basically conducted small studies before surgery, asking the question, is this particular drug effective, this particular target, if the target is present? Unfortunately, the vast majority of these experiments were negative, with one exception, and the one exception was pembrolizumab. Pembrolizumab is an immunologic drug that is directed not necessarily to the tumor, but directed to the lymphocytes that we carry in our bodies that have the capability to kill tumor cells. And this drug is now approved, is approved for many tumor types, but also for breast cancer. In fact, is approved for triple negative breast cancer and is approved in the neoadjuvant setting, is approved as a single agent to continue after adjuvant therapy is completed, and is approved for metastatic disease in the tumors that present lymphocytes infiltration with a high proportion presenting this particular receptor. Now, there are many agents in this class of treatment. I actually participated to the introduction of the first two agents in this class for melanoma, actually not for breast cancer. And they're now being studied in breast cancer in different subgroups of patients. In fact, as early as February of this year, and as early as the spring of this year, ASCO and ESMO modified their recommendation for metastatic disease And they said that in tumors that present rich content of this receptor, pembrolizumab should be used as a first line. And this is actually accepted also by the Europeans. Now, as I said, we're looking for rich presence of this receptor. Another company that is developing similar agent has thought to going after a different type of biomarker. And we know that the tumor that mutate very frequently and therefore present a high tumor mutation burden are the ones that are more likely to respond to immunotherapy. So this particular agent has been used now in breast cancer in experimental trials, looking for patients that have tumors presenting a high tumor mutation burden. Now, we don't know yet which is better. So far, we can tell the PD-L1 high expression is the preferred way to diagnose these tumors and to recommend this treatment. But things may be changing in the future. Of course, when you talk about immunology, we also talk about vaccines. And there are vaccines that now are being developed in breast cancer. In particular, these two, one of them is not even been named yet and are going on in clinical trials. Also, you have heard about the CAR T-cell modality. What this modality is happening when we remove from a patient the T lymphocytes, not the tumor, not the tumor cells, the T lymphocytes. In the lab, we instruct them to attack the tumor, and then we re-inject these cells into the patient. This type of approach has been dramatically effective in leukemias and in lymphomas. So far, unfortunately, it has not yet been proven to be effective in solid tumors, such as breast, lung, colorectal, or other type of tumors. But I'm sure that as we proceed, we will be able to identify better manipulations of our own lymphocytes that will make them more effective against these solid tumors. Of course, there is not only killing and shrinking of tumors, there is also quality of life. And we need to pay a lot of attention to side effects, particularly now because the treatment of breast cancer, as I indicated, has evolved into long-term perspective. And we do not want to inflict long-term side effects to women that are doing well in terms of controlling or curing their tumors. Of course, every woman that receives hormonal therapy knows what it's like to deal with hormonal treatment. And in fact, the most common effect of hormonal treatment is hot flashes and back pain, joint pain, fatigue, headache are very common. More recently, more attention is being paid to psychological side effect, and anxiety obviously is a frequent side effect associated with long continuation of treatment. Of course, the aromatase inhibitors are an extremely effective class of agents, but they also have some effect on the bone, on the regular, of the healthy bone of the patients. And in order to prevent the weakening of the bone structure that the aromatase inhibitors and other hormonal therapy bring along, we use biphosphonates. And we use biphosphonates also in the adjuvant setting. Now, biphosphonates are approved not only for the treatment of patients with breast cancer, they're approved for patients that have simply bone disease or bone weakness or arthrosis or this type of diseases. So to associate a biphosphonate with hormonal treatment, particularly if it contains an aromatase inhibitor, is something that now ASCO and also the Canadian guidelines recommend. Early this year, in March, there was a symposium in this country, in Florida, that had a lot to contribute to the knowledge of what we're doing for patients that present with brain metastases. Now, let me say one thing. I have participated, as it has been said before, to the establishment and to the introduction of standard of care for ovarian cancer. And that was paclitaxel, a taxane, plus carboplatin, a platinum. In ovarian cancer, we rarely had seen brain metastases. With the introduction of these new agents, now we see survivals that are very, very, very long. And then guess what? The tumor may come back in the brain, and back in the brain because paclitaxel, docetaxel, carboplatin, cisplatin, they do not enter the brain. Now, what we are seeing now in breast cancer is something very similar. Patients live longer and longer and longer and longer, and then we start seeing an increase of the number of patients that present recurrencing of their disease in the brain. So now developing drugs that are effective against breast cancer, but they can also penetrate inside the brain, provides additional tools to not only treat, but also prevent the occurrence of brain metastases. And again, they could be antibodies, they could be targeted agents, they could be small molecules, but they all have proven some very promising results in not only treating, but also in preventing brain metastases. Palliative care, treatment of pain, treatment of side effect is also part of the wholesome approach to patients with breast cancer. Unfortunately, still, even in this country and not in, underdeveloped geographies, there is still a tendency to associate cancer with a negative, disenchanted, losing type of attitude. Now, these are patients that could have highly benefited from palliative care, and actually 2/3 of them did not receive any palliative care in St. Louis, in Missouri. So we need to keep in mind that we need a total approach to the disease, treating the disease, treating the side effect, supporting the patients both physically, psychologically, and genomically. What about the genomic risk? Well, that's also very interesting because in 2020, ASCO and the Association of the Radiation Therapists issued recommendation guidelines for patients that present BRCA1, BRCA2, or other mutation. And in 2020, they said, well, there is no sufficient data to recommend the PARP inhibitors in the adjuvant setting. Guess what? This has been modified, and has been modified because of the recent data of olaparib in the adjuvant setting. So this recommendation is no longer in place, and ASCO and ASTRO do recommend the use of olaparib in patients that have BRCA mutations. Again, this tells you how quickly the scenario is moving and changing. And of course, in a small minority of patients, breast cancer affects also males. So please, when you do advocacy work, do not forget about the boys. I want to thank you for your attention today. I'll be more than glad to take the questions that you might have. I saw already that somebody had asked me to repeat the standard testing modalities for HER2. One is called immunohistochemistry, or ICH. The other one is called in situ hybridization, or ISH. These modalities are available and FDA approved today all throughout the country. And I'll be glad to take your question. And I really want to thank you for your attention.
Dr. Canetta, that was terrific. Thank you so much for taking the time to both put this together and, of course, prepare and do today's presentation. We greatly appreciate your passion for the issues and your compassion, and your knowledge base is just substantial. I want to mention to the audience, the slides have a lot of information, and we will make them available if you want to study them further, because as he said, we weren't going to ask you to memorize and then give you a quiz. But you know, you may look at them later and scratch your head and have some questions or things that you wish to discuss with your own healthcare team. And so we will make them available. I also want to say that sometimes the information is dense, but you'll get from it what you can and what you kind of need. And while it's a lot of science behind the slides, or that Dr. Canetta was even speaking to, we at 2Life have always believed that more information is better than less, and we don't like to water down, especially when we have some really exciting new treatment opportunities that are here today and are coming, you know, as I said earlier, to the pharmacy or the physician or the hospital near you in the near future. Better you know more rather than less, and that's our objective, is to, I know it's a trite thing, but to empower the patient. We want you to be better partners with your healthcare providers in discussing what's good for you as a patient. And I have a couple of questions that I'm going to toss out to Dr. Canetta to get the discussion going. And I see that we have some more questions in the question and answer box on the screen. So keep those coming and we will address them as we proceed. So one of the things, Dr. Canetta, that comes to mind is with this new exciting standard of care with, I'm just going to say TDXD, because I can't possibly pronounce all that. And we used to maybe as a patient say to the doctor, okay, you're testing me for HER2, are you going to use IHC, are you going to use FISH? Basically, are you saying that really doesn't matter anymore, you know, which modality they use? How should we strike up a dialogue with our physicians so that we're then discussing the use of TDXD in our personal journey?
Okay, so let me make 3 points here. Number one, the most relevant thing, immunohistochemistry and in situ hybridization are the tools that we have today. They should be used, okay? And they should be used to identify patients that need the standard HER2 positive treatment, but also they might need the newer type of treatments. Point number two, related to the diagnosis. If you think of it, we're learning from the biology. So what did we learn? We learned that testing more, we can identify other subset of patients that can benefit from novel therapies. So what I expect, and I'm saying this because I know that several universities and research groups are actually doing this type of research. I expect that we will come up with novel diagnostic tools that instead of looking at tumor cells, instead of looking at in situ hybridization, they will be actually able to quantify and give us a number that will tell us, okay, this tumor should be treated with that particular antibody, that particular small molecule, or a cytotoxic chemotherapy. So this is something not unique or of the drug that I've shown that I cannot pronounce, but ends by deruxtecan. I mean, there will be other drugs in this category, but I think what is important is that we focus on the fact that there is hope, there are options today that are available that patients up until today would have been perhaps undertreated or overtreated. And you've seen, you know, the standard treatment for this patient would be cytotoxic chemotherapy with lower efficacy results and with more toxicities. So I want to be very clear about that.
So thank you. That's, you know, again, just knowing that there's something so new and so revolutionary for a large swath of the population is encouraging. And speaking of survival, which has been improving, obviously. So something else you mentioned, and due to the long-term survival, you mentioned it first with ovarian cancer patients. And you know, you're seeing it now, we're seeing it now with breast cancer patients, which is brain mets after a long relative period of calm, if you will, dealing with what we now view as a chronic disease. What kind of follow-up should a breast cancer patient, you know, in general have? What kind of conversations should they have as they are finishing up treatment for metastatic breast cancer, if they've done quite well, or even, you know, not? What kind of discussion should they have with their healthcare provider on appropriate follow-up to make sure that if there are brain mets, they're, you know, they and the providers are on top of it?
Okay, a very good question, and I'll make 2 points. I always go by points, so sorry. It's my mental form that I learned in Milan, as you can see. First thing, you don't need to recommend CT scans or MRI on a regular basis. You do not. Why? Well, because not every patient will recur. Not every patient will recur with the brain metastasis. However, when you do the follow-up in time, and I'm talking about the long-term follow-up, 5 years, 10 years, and go on, your healthcare provider must be reminded of this possibility. Now, what does it mean? It simply means that when you do a physical examination, you can do the neurological testing and then start from there, or asking a question of the patients. Have you seen a different behavior? Have you lost sleep? I mean, there are a number of red flags that can direct a physician and a patient to do further investigation. But I want to be very clear. The incidence of brain cancer, of brain recurrences from breast cancer, sorry, it's increasing, but it's still a small proportion. The majority of women with breast cancer that are diagnosed early are cured, okay? And they will never recur, hopefully.
So thank you very much. And it just behooves us as patients to have good discussions with our primary care physicians when we have our annual or whatever, you know, periodic physicals. And of course, as we age, they're just testing us, asking questions all the time neurologically to make sure, you know, there aren't other issues such as dementia or whatnot. So it's just part of the package as we age, in part anyway. So I noticed that there's at least 6 questions in the Q&A, and I just want to call out that Dr. Canetta will be answering questions for the next few minutes. He will not be giving specific personal evaluations, obviously, for anyone's course of treatment, but more generic responses. And of course, you can follow up very specifically with your own healthcare providers for your personal situation. And with that, I'm going to turn it over to Eileen and Dr. Canetta for the rest of the questions and answers and for the closeout today. Thank you so much, everyone, for joining us.
And I'll be happy to address them in order as they came up. So the first question has to do with a specific mutation presented by a person that had also another type of malignancy, a uterine tumor and a ductal in situ breast cancer. And the question is, when there are mutations, should we think in terms of prophylactic mastectomy, double mastectomy, single mastectomy, and so on? The answer is actually, we know that for the BRCA1 and BRCA2 mutation, there are certain institutions that are recommending prophylactic mastectomy. Now, they're doing that when they take into consideration not only the individual patient tumor characteristics, but also the family, the siblings, the history. Okay. Now, they're doing this for BRCA mutation. For the novel mutation, I don't think we know enough to make a stern recommendation. And again, in these particular cases where the information is really new, the best course of action is to have a very frank and open discussion with your physician. And your physician will take into consideration your family history, your age, the history of your other tumor, the history of your in situ breast cancer, and then make a recommendation. I don't think there is an absolute right or wrong answer, but I think there are many options available here. Surveillance, that it has to be frequent, or surgery that will anyway have to be followed by surveillance. And also, and this is not to be forgotten, interrogating about the status of the family, the children, the grandchildren, the sibling. These are group of population that could be at risk. So again, you take the totality of the picture on the horizon. Now, since we spoke about BRCA, I'm going to answer a question that is 3 points down. Somebody asked whether the PARP inhibitors attack a specific mutation. And the answer is yes and no. And I'll tell you, yes, because they do inhibit BRCA1 and BRCA2. Why am I saying no? I'm saying no also because more recent data that came actually not from breast cancer, but came from prostate and from ovarian cancer, indicated that there are other type of mutation that we can call HRD, high mutation burden, if you want, or high residual mutations. And the PARP seem to be offering a good option even for these patients, even if they don't show BRCA1 or BRCA2 mutation. In fact, even if you look at the current label of olaparib, olaparib is not only recommended for patients with BRCA1 and BRCA2 mutation, but in the early stage, there are a number of broader authorization of the use of olaparib. So I think I answered the fourth question. Now,
You
somebody
certainly did.
asked, I'm sorry.
Keep
Somebody
going.
asked, what are the mutation of the estrogen receptor? Well, basically, first of all, what are receptors? Receptors are protein that sit on the surface of our cells. Tumor cells or also normal cells. With time, with age, all the receptors can degrade and mutate. In a relatively small proportion of breast cancer, when breast cancer is treated with tamoxifen, with aromatase inhibitors, with fulvestrant, that can pressure the tumor cells that try always to outsmart us to mutate, and to mutate in a way that all these modalities will no longer be effective, because a mutated receptor can take advantage of the hormones that we produce with our body and feed the tumor instead of doing what they're supposed to do. So having a class of compounds that can affect mutated estrogen receptor can actually provide us with yet another tool that we can use from our toolbox. Then there is a question that has to do with the fact that all the tissue can be checked at the time of disease progression to guide the new treatment. And the answer is absolutely yes. Absolutely yes, if all the tissue has been properly taken and properly stored. But you know, many of the tests that we use do not require fresh tissue. So they can be, the tests that we have, they can be utilized on all the tissues. However, there is a big caveat, and I need to tell you this, and that is the following. Tumor change with time. They always try to outsmart us, or they simply get older as we are, okay? So if you find in the original diagnostic test a particular, in the original diagnostic specimen, tissue, a particular mutation, that mutation or that genomic signature may not actually be present many years later. So it is true that you can use the test that we have on all the tissue, but it's true always that fresh tissue, or anyway, contemporary specimens are always the best to test, because they tell what the disease is now and not 5 years earlier, 10 years earlier, and so on. If you see my picture of 20 years ago, I looked to be a little bit different, certainly with less white hair.
I think we all look different 20 years ago.
And on this theme of the mutation are today found in tissue, okay? So you need the specimen taken at the time of the surgery or with biopsies, and that's what you use to test for receptors, because you need cells to see if there is a receptor present on the cell. Or you need the DNA inside the cell to check for mutation. But that's exactly why I have this great hope in the circulating DNA. What is circulating DNA? This is DNA that comes out of dead cells, because, you know, tumor cells actually die with time, and their DNA can be retrieved with a regular blood test without taking a biopsy, without doing surgery, without, you know, taking small specimens out of the tumor. By testing the blood and looking for DNA, we can now identify tumoral DNA in the blood test. And this is what we call circulating tumor DNA. And that's the big open question that I referred to in a part of my presentation. And now I can go to the last of the written question, which is there a recommended stage 1 HER2 ER positive screening protocol with 20 oncotype score? Let's split my answer in 2 sections. Section 1, if you're talking about the original tumor, you can use the original specimen to apply Oncotype DX, which is the 21 genes, or MammaPrint, which is the 70 genes, or any of the other approved tests for genomic. You can use those on the original diagnosis. You can use also those if you need to access tumor from a relapsed location. However, and that's an important caveat, what you do when you test a relapsed tumor, the Oncotype, the MammaPrint, they don't really give you the appropriate information. They tell you you are at risk, but they don't tell you much about the treatment. It is a different type of testing, like the one that I said before, immunohistochemistry, in situ hybridization, or other genomic testing that can tell you, well, maybe I should use the CDK inhibitor. Maybe I should use a PI3K inhibitor. Maybe I should use a PARP inhibitor. So again, the Oncotype DX or MammaPrint are very, very good at the original diagnosis. When the tumor relapses, I believe there are better tools to use.
Okay, and there we have it. Thank you very much. I think that does clear our questions. I think we're at the point where we have answered questions from the audience as well as from Mara, and probably your presentation would be interpreted as asking all the questions that none of us really knew what to ask for. And clearly in your presentation, Dr. Canetta, you took so much of both the knowledge that you had throughout your career, as well as from the recent conferences in the hours of presentations, and gave us I'd say some really good, encouraging news for current and future treatment, as well as a window into how to have certain conversations with our physicians as we go forward. So, you know, as Mara commented earlier, we ask good questions, and you know what? There's always something new to learn. I think of that as I think one of the delights of life, that there's always something new to learn.
And if you allow me to add a final personal note on my side. As you have seen, what I spoke about today are very recent information. And if you want, there are information that today conflict with things that I've been doing in my career, in my life. Like I said, in the early 80s, in the late 70s, we were proving that chemotherapy after surgery is worth using. Today, we are trying to disprove the chemotherapy is the best option and to provide a better option, okay? So I guess what I'm telling you is that never be afraid of change, because reality always teaches new things. So never be afraid of asking questions. And I would say, never be afraid of hope. Because if you think of what we spoke about today, we spoke about a disease that when I started medical school in the Jurassic age, it was a dead sentence. No longer is what we thought so many years ago. Now we believe we can help patients and families and healthcare providers so that this type of occurrence in the life of a person, which we call disease, is part of life. And that's why I'm so grateful about your organization, because you really underline and stress the importance of life. We are working, we're doing everything that we do to improve and make worth our lives. Thank you for everything that you do in supporting our patients.
Well, you know what? This was an extremely informative and well-presented talk. And so I'm delighted that you were able to take time with us, Dr. Canetta, both from the preparation side and then, of course, this morning. As I'd had the opportunity to review your slides in advance, there was a part of me that was a little concerned that says, oh my goodness, there's so much information here. How are we going to get through it? And as everyone can clearly attest, you smoothly sailed through bringing us the salient points and pointing us in ways that we can take what you've given us and understand both some of the drug classifications just a little bit better. I know I learned a number of really important things. And so anyway, so for everyone who's on the call now and participating, I want to thank you for being part of today's presentation and for your interest in both the developments that are coming forward and into Life as an organization. I will present, there will be a copy of this recording made available after the program. You will be sent, for everyone who registered, you'll be sent a link directly to the recording. And as soon as we just have to do a little bit of probably of editing on the back end, but then we will also make it available up on our website. And so I think that would cover it. I want to say thank you again to our sponsors. And the last thing is that I will also send out a post-event survey just to get some feedback so that everyone, including Dr. Canetta, can get some feedback from us as a community so that we can make future programming relevant to the needs of our community. You know, I don't pretend that I know exactly what we need, and probably Dr. Canetta doesn't either. But we want to make sure that our programming is relevant. I will also mention that we have the Women's Health Conference series that will be coming up in the fall. We're going to continue to work virtually this year with the hope, and I'm going to keep my fingers crossed that we can go live with our programming going into next year. And indeed, we may move forward in more of a hybrid model as opposed to one or the other. And I think that's where life is moving as we move forward and manage both the health and safety with being together. And so hopefully too, you'll see us with a breakfast meeting next August. And so I want to say thank you and close it out for today. It's just about 10:30, so we've used up all of our time, but I think we've used it wisely. Everybody have a great day. And if you've got any further questions, just send an email over or call the office. www.2life.org. Goodbye now.